Starting the broadcast now. Hi everyone, welcome to the Monash FODMAP webinar. Just wanted to say apologies for the mix-up with the timing. That was my fault. So my name is Dave McManus. I'm the founder of Tuki. Tuki is a product specifically for dietitians, software product, and we're really excited to have Professor Jane Muir from Monash University joining us today. Jane, a bit about Jane. Jane is a nutrition scientist and dietitian with 25 years experience in the area of nutrition research. She's the head of translational nutrition science at the Department of Gastroenterology at Monash University in Melbourne, Australia. And we're really excited to have her presentation today on FODMAP diet. And without further ado, I'll hand it over to Professor Jane Muir.
Okay, thanks Dave, and hi everyone, and sorry for that mix-up. I am in fact 12,000 kilometres away in Melbourne, Australia, and we are on daylight saving time here, so it's summer here, so I'm sorry about that. And the funny accent for Dave and me is the Aussie accent, so you'll just have to put up with that as well. So welcome, and I'm glad you could hang out for this webinar. And what I'm going to do today is take you through this it's a very exciting new area for dietitians to be working in. Monash has been leading the charge. We're the founders of this diet, and we are very passionate about getting dietitians educated in the US about implementing this diet to help our patients with this terrible condition, IBS. So today I'm going to just go through really the clinical problems of IBS, discuss that. I want to talk a bit more about low FODMAP in detail and low FODMAP criteria that we use. And I want to go over really the dietetic management of IBS, so how we recommend people tackle this problem of IBS and the dietary therapy of the low FODMAP diet with their patients. And I'll have a case study also, and I also want to talk about how to use the Monash FODMAP app, because that is a really valuable resource and tool for you to use when working in this area. So let's just review the clinical problem of IBS. The symptoms of IBS include abdominal pain and bloating, distension and altered bowel habit, and it can range from diarrhea to constipation. It's the most common GI complaint in our community. Around about 10 to 15% of the population. In the US, it's around about 50 million sufferers are predicted to be there. The causes are complicated, but they involve a number of factors. Alterations in the gut microbiota is probably involved, so a dysbiosis of the gut microbiota, but also disturbances in motility, low levels of inflammation. And these people have a visceral hypersensitivity, which means their gut is just very sensitive to distension. It significantly reduces quality of life of these patients. In fact, a survey that was done fairly recently identified that patients actually identified that they would sacrifice 10 to 15 years of their life for an immediate cure. So it has a major impact on people's quality of life. So the economic burden of this disease is high, and there's very few quick fixes, no drug quick fix for this condition at all. There's a lot of overlap with IBS symptoms with lots of other disorders of the gut, and just in general, there's these gut symptoms tend to overlap with a number of conditions. So it's very important to get a good diagnosis of the patient. They need to be reviewed by their doctor and have a correct diagnosis to make sure that there's nothing more serious and sinister going on with these patients. Particularly, they'll be looking at celiac disease, inflammatory bowel disease, and also colorectal cancer. So that's important to emphasize with your patients. Of course, there are alarm features that all dietitians must be aware of and look out for when people are presenting with these symptoms also. Things like unexplained weight loss, family history of bowel diseases, age of onset, bleeding, fevers, all these sorts of things, vomiting, and nighttime, getting up at night to open their bowels as well. So there's a number of red flags that we must all look out for as health professionals when we're interviewing these people. There's a number of modes of treatment have been used over the years. The pharmacological therapies historically not been fantastic at managing all the symptoms. They tend to target one particular symptom at a time. So they haven't been terribly successful. There's certain psychological therapies available, and certainly gut-directed hypnotherapy, behavioural therapy can also help manage this condition, manage the stress often associated with this condition. It's quite costly, and it can be difficult to find good therapists who've got expertise in this area as well. Of course, there's diet therapy. A range of diet therapies have been trialled over the years. We know that just a high-fibre diet doesn't work, and that's what we used to recommend to our patients. We used to play around with fat and caffeine and alcohol with moderate success. The gluten-free diets provide some small benefit, but generally it's the low FODMAP diet now has become the first-line approach for managing this condition. And really, it's not surprising that food is involved with inducing the symptoms, because our patients have been telling us that for years. So 60 to 80% of patients with IBS will all claim that certain foods trigger their symptoms. But there's such a wide variety of foods that have been implicated, it was really, really difficult to know which particular factors might be the candidate triggers. So when we started researching this area 15 years ago, we really wanted to hone in on the main candidates that we thought were likely culprits, and these are the short-chain carbohydrates. And the reason why we thought these are most likely to be, worthwhile study is that they do have gut effects. They've been well known to have gut effects. They're osmotically active. They draw water into the lumen, into the gut. They can be fermented in the bowel to produce gas. So they actually had a lot of characteristics that would explain the symptoms of IBS. So these short-chain carbohydrates, we've been studying them for decades. You can see from this slide that lactose, since 1965, has been known to cause problems. There's fructose, sugar polyols, fructans, and GOS. All through the decades, we've been looking at these short-chain carbohydrates in isolation, and we know that they can cause gut symptoms. And really, the FODMAP hypothesis is simply an umbrella term that brings together all of that knowledge under one umbrella term, so that we can study all of these sugars together and see whether these may help our patients. So FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Excess fructose, and they include excess fructose, lactose, fructans, GOS, galacto-oligosaccharides, and sugar polyols, mannitol and sorbitol. And they are found widely and naturally in our diet. I've got this little animation, and I don't know whether that's going to work actually, Dave. Oh, let's see if it will work. Yes, let's try. This is an animation that will hopefully show you, how FODMAPs trigger symptoms in the gut. And let's see if that will work. And I don't think it's going to work. Oh, no, here it goes. So this is an animation. We do have it available on YouTube, and it's a very handy tool for teaching patients. So we explain that FODMAPs, this is the small intestine, and this is actually the lining, the cells that line the intestine. These are enzymes that digest sugars, break them down into monosaccharides. This is normal carbohydrate digestion, if you like, sugars. And the sugar monosaccharides are pumped into the cells. But FODMAPs, for a range of reasons, we don't have the enzymes, so we're not absorbing, not digesting and absorbing them. So they remain in the gut, in the lumen. And that has a number of consequences. They attract water into the small bowel because they're osmotically active. So they draw water in. They also will reach the large intestine where the bacteria reside. And the bacteria then use the FODMAPs, the sugars, as fast food, if you like. They just use them for their own metabolism growth. And as a byproduct is a lot of gas. A lot of gases are produced. And the combination of all of this gas and all of this water that's been drawn into the gut causes distension, enormous amount of bloating, distension. And this triggers nerves around the gut to the brain to trigger the pain and discomfort that these patients feel. And people who have got IBS have a very sensitive gut, and so they do sense a lot of pain and discomfort. See if I get to the next slide. Okay, so what is low and what is high FODMAP? So Monash actually established the cutoff values for FODMAPs in foods. We've done a lot of food analysis over the years, and we have published these cutoff levels. There's a reference there for you. So we defined really low based on initially our clinical observations for what we felt patients can tolerate, plus our knowledge of what was in food. And we set the bar really at this level. And then this is what we've used in all of our studies to then provide evidence, clinical evidence that these cutoff levels are in fact effective. So where are they found? So a huge cornerstone of the work we do at Monash is analysis of foods for total FODMAP content. And you can see from this slide that there each food category will have different types of FODMAPs, I guess, existing. Some foods, particularly fruits, tends to be fructose and sugar polyols, and grains and cereals tend to have fructans. So different food groups tend to have different types of FODMAPs. And each category of food has different, they usually have a low and high FODMAP foods. And when we apply our cutoffs, if you like, you can see that there's usually a food in each category that would fit, would be low. We would consider low FODMAP, a low FODMAP alternative. So this is sort of one of the key principles of the low FODMAP diet, that it really is not an elimination diet. We're not eliminating food. We're more replacing a high FODMAP food with a similar but low FODMAP alternative. All of our knowledge on food composition, of course, we share with everyone through our smartphone app. The Monash University Low FODMAP Diet app has hundreds and hundreds of foods. In the app, it's always being updated with new foods, and the money raised goes to support the research and analysis of food. So it's a great thing to support, and it's a fantastic tool for anyone working in this area, for dietitians and for the patients. So let's talk about the efficacy, the scientific efficacy for the low FODMAP diet and IBS. And this first study here that was done by our group, by Emma Halmas, who was a dietitian undertaking a PhD with us. This was sort of a landmark study really showing the effectiveness of the low FODMAP diet. And it was compared to sort of pretty much just a typical Australian diet, if you like, and just altering the foods in that diet to make it to be low FODMAP alternatives. And the results are very, very significant. But this work now has been reproduced around the world. So really in the US, the UK, Canada, there are studies now, there's about 11 or 12 studies around the world confirming the safety, the efficacy of the low FODMAP diet in IBS and treating the symptoms of IBS. And importantly, it's 3 in 4 patients with IBS will benefit from this diet. So it works. The safety of the low FODMAP diet has come into question, and we published this a number of years ago that we did find there are changes in gut microbiota during the low FODMAP diet. Now this, we don't really understand what the changes would mean, but this is an important point that FODMAPs really are prebiotic. They're not bad, they're prebiotic, and for this reason, we really emphasise the importance of not being on a strict low FODMAP diet for the long term. And it's important to use this information really with your patients to encourage them to reintroduce, which is part of the program, the reintroduction phase, and how important it is for people to reintroduce as many FODMAPs back into their diet to really help feed their microbiota. So how do you follow the diet? The diet program, the low FODMAP diet program, is a three-step. It's a three-step process. Step one is the low FODMAP diet, and we recommend you follow this with your patients for 2 to 6 weeks only. Step two is the reintroduction phase, where each FODMAP subtype is reintroduced one by one to work out which is your particular trigger FODMAP, because everyone varies in which particular sugar will upset their symptoms. And this process can take 6 to 8 weeks. And then the third and final step is the personalisation, where the dietitian interprets all of the results of the reintroduction, and based on this, as well as discussing with their patient, work out a diet for that particular patient. And that's the one that they will go on for the longer term. And it's a very much less restricted diet. We do not want people on strict diets for the long term. The dietetic management of IBS, it's terribly important to have a dietitian involved with managing patients with this condition. We think the dietitian has a vital role to play in it being successfully implemented with the patient. And there's evidence coming out now when dietitians are involved, there is a much better outcome for patients. So they do better following this diet. So let's just go into the step one, low FODMAP diet, in a little bit more detail. So the aim of this step is really just to induce symptom relief. And we really just want to restrict all the FODMAPs for 2 to 6 weeks. So all the different FODMAP subtypes for 2 to 6 weeks. So, and it really is a substitution of low for high, low FODMAP alternatives. So you really are swapping out the high for the low alternatives. And it is probably the strict version. The idea for doing this is we want to get people well fairly quickly. A lot of these people have been going from doctor to doctor and health professional to health professionals trying to work out what they can do to control their symptoms. So if the FODMAPs are the problem, we want to get it to convince them that we sort of, and yourself and the patient, that you've actually got the answer fairly quickly, get them well, and then start the reintroduction process. So the dietitian really also has an important role at this stage to assess for the clinical assessment and also screening for red flags. Of course, we do our standard dietary assessment for nutritional inadequacies. We also can determine really the extent of a FODMAP restriction that might be required, and that depends very much on the patient that is coming in to see you. There are some cases where you would not even recommend a low FODMAP diet, and I'll talk about that at the end. And of course, there's obviously education and practical issues, and just explaining how FODMAPs work and how they trigger symptoms is terribly important, using the animation that we have on YouTube, food labelling, meal planning, and recipe modification. Using the app, of course, is a fantastic tool to help navigate the food out there for patients. Now, the step two, the reintroduction phase, the aim is to identify sensitivities to all the individual FODMAP subgroups and find the balance between good symptom control and just expanding the diet. And we think this is a really important step. And it's very important at the very start when you see your patients for the very first time to explain to them this 3-step process. So they'll be expecting and understanding that there will be this reintroduction step. And the reason why it's so important is, of course, that FODMAPs are prebiotic, particularly the fructans and galacto-oligosaccharides. And so we do not want to over-restrict for this reason. It's important to feed our gut microbiome. And I think everyone is very interested in their gut microbiome these days. So it's actually quite a good way of encouraging people to do this step. We also want to improve, the variety of the diet, social inclusion issues, and it's important that patients learn their own triggers and can manage their condition themselves. So it really is very much a learning diet where the patient learns which particular triggers are their problem, which foods they're found in, so they can manage their own forward. The reintroduction phase really is probably the most complicated phase, and that's where the dietitian has such a huge role. It's really finding we have to look for foods which just have really good sources of the various rich sources of the various FODMAP subtypes, because a lot of foods have a combination of different FODMAPs. So, for example, to find for fructose, honey is a very good source, and mango is a very good source of just having excess fructose. Of course, milk is a very good source of lactose, and so on. And I've got here a table to explain the sorts of examples of suggested foods that you might discuss with your patient, and the sorts of levels that you might recommend that they start reintroducing. And this has to be done with the background diet being low in FODMAP, and it's just one at a time, one subgroup at a time, for about a 3-day period, and then a few days in between to recover before they start the next challenge. And their symptoms really have to be recovered before they go on to the next one. We usually like to ask patients what food are they really missing, so that will guide as to which you might try first, which particular FODMAP reintroduction you'll try first. And you often have to adjust the amounts depending on their symptoms severity as well. And these are examples of, again, the different FODMAPs present, which sort of food challenge you'd use. And we like to teach patients to come up with their own challenges, of course, as well. Step 3 is the personalisation, and this is really, we want to liberalise the diet, expand the diet. This is going to be their diet going forward. And the dietitian really, again, identifying the subgroups of FODMAPs that is a problem for them, and then tailoring the education while establishing and ensuring that they have a nutritionally adequate diet, their own personalised FODMAP diet. Provide ongoing support, and sometimes there's other diet therapies that we might suggest, particularly if patient has constipated predominant IBS. You might want to talk about suitable fibre supplements going forward. And it's important to teach patients about relapse situations, because there will be the odd day when they really feel they've had a bit of a relapse, they've accidentally eaten something, and it's just important to understand that that will be fine. In a day or two it will calm down, to understand really the reasons why they've had a relapse, and not to be too concerned about it. And we encourage and teach patients to keep going and reintroducing food, so they really do learn how to manage this condition themselves. So troubleshooting with this diet, if there's no response to the diet, which is, so the diet works for 3 out of 4 patients, there's obviously, or 75% of patients do well, what happens to the 25% that do not do well? The first thing that we would do is to make sure that they actually have a correct diagnosis of IBS, and that they did adhere to the diet well. So you make sure they have actually followed the diet well. We usually recommend that they stop the low FODMAP diet, so they really do need to reintroduce all the FODMAPs back into the diet. And sometimes you find when people do that, they feel terribly uncomfortable, and so the the diet was working for them to some extent, and they reintroduce the foods, they do feel discomfort again. So it's important to sort of really understand what the no response is. If there's really no response, there's no FODMAP involved, they don't need to be on a FODMAP restriction then. So they bring FODMAPs back into the diet. And this is where you have to look at other therapies. You have to work through some other ideas with them. Patients can find the diet very hard and complicated. They can feel very overwhelmed, and this is where the dietitian again has a vital role to play, and how to negotiate eating out and so on. Patients often don't want to reintroduce FODMAP, so it's a major discussion over that step, which is terribly important. And we find discussing the importance of their gut microbiota really does help in that conversation. To start, you do have to start the reintroduction when the patient's ready, but it really does need a lot of encouragement and discussion to get them to go through that reintroduction phase. Sometimes there are other non-diet therapies that can help, and we use gut-directed hypnotherapy with some of our patients, and that's been terribly useful as well. So you can explore some other ways to help these patients as well. There are some contraindications for the FODMAP diet, which is important to consider. If you have a patient presenting who clearly has an eating disorder, it absolutely is not appropriate to put them on a strict low FODMAP diet. So they're already on strict diets. So you need to find another way of managing those patients, but certainly it's not appropriate to go on a strict low FODMAP diet. Also, if there's a situation of malnutrition, terribly elderly people, very young children, and people who are just unwilling to apply the diet, we might recommend just a more very simplified approach. You might not even use the word FODMAP with some of these patients, and I think it's probably a good idea not to sometimes, because there's so much on the internet, that you just simply can modify their existing diet, and as we call it, a simplified FODMAP approach. So using your knowledge of FODMAPs, you modify their existing diet, and hopefully that will be enough to provide relief for them, and they won't need to go through the 3-step process. But often with children, it can be an excess intake of fruit juices and things like that. So it's just really modifying a few simple things in their diet. Now, just to go over some of the resources that we have developed at Monash to help dietitians to implement the diet, our dietitians toolkit. So the app, of course, is sort of the cornerstone of our toolkit, if you like. It's the really on-the-go best guide to FODMAPs and IBS. It really is how we deliver our knowledge around the world. So it is downloaded in over 130 countries now. It's the top FODMAP app and one of the top medical apps in the world. It has the largest number of downloads in the US now, so we do know that this diet is gaining a lot of interest in the US, so we're very keen to help ensure dietitians are skilled and knowledgeable in this area. And we're not-for-profit, we're a university, so the funding goes towards further research and also further food analysis. So it's a terrific way of supporting research. The app itself, if you haven't seen it, the first guide page, if you like, there's an awful lot in the app. There is the heart of it is probably the food guide there, but there's recipes, over 80 recipes. There's a booklet on IBS and FODMAPs, which is very popular. There's diary to help recording food intake and symptoms and reintroduction. I can take you through that in a little while, a bit more detail. We have certified Monash food and beverages, so we're working with food industry to design foods that would be suitable and tolerated by this patient group, so they're low FODMAP certified, and they're listed there in the app under certified goods. They're also in the food guide. We have tutorials there, Start the Diet, just like a 3-step diet just to take people through. We have tutorials about how to use the app. And of course, we connect with our FODMAP community. We have Twitter and Facebook and Instagram, and we have a very active FODMAP community there. The app uses a traffic light system, so to help guide people through which foods are low and which foods are high in FODMAP. So the very low foods that are low in FODMAP are green and they're safe to have. Amber is moderate, and of course the red are high and should avoid. Again, it's this concept of swapping, food swapping, if you like. So you're swapping out high FODMAP foods for the low FODMAP alternatives. So it's really not a strict elimination. It's just finding suitable alternatives in the same food group that are lower in FODMAPs. So step 1 of the low FODMAP diet, which is a low FODMAP phase, you really need to get familiar with how to use the food guide, which is there in the app. And when you open the food guide, you can see all the different categories of foods that we have. And you click on, for example, there, that's fruit. You click on fruit and you can see the ratings there, the traffic light ratings on the right-hand side, which is the overall traffic rating. And then under each food, you'll see that there are some different colours and serving sizes. That basically is showing you the serving size that gives you the certain rating. So even though red foods, so avocado, which is that rating is based on a typical serving of avocado, we can see from there that there is actually a small safe serve of avocado. So even a food that we would say is high FODMAP, there may be a small safe green serve of that food. So again, we're trying to expand people's diets and show them what foods they can eat, but maybe it's smaller amounts, so it very much is a dose effect. So this is a very, very useful app for showing serving size, a concept of serving size. And for example, so you click on avocado, again, you'll get all the individual FODMAPs there to see which is the one contributing to the rating, and it is sorbitol. So avocado is very, very high in sorbitol, and that is what's giving the overall rating for that. To find certified food products, you just need to click on that, and you can, there's different companies. Oops, I'm going back. We've got many, many companies now and many foods that are certified low FODMAP, so patients can eat them with confidence. The second step, which is the reintroduction, we think it's very useful to use the, actually it's the diary, which is on the lower right there. If you click on the diary, you'll see that there's a little plus in the top right-hand corner, and this sort of the little apple, if you like, our reintroduction symbol. You click on that, you come to this page, and in there, you'll be able to choose the type of FODMAP re-challenge you want to do with your patient, and it gives you examples of the amounts of that particular food that you'd have to have. For example, this one, we decided we're going to do a fructose and sorbitol re-challenge, and we've selected to do that with a pear, and it's giving you the serving size there. There's a food diary that will go straight into the food diary, so the patient can actually record what they're eating, and they can see that how much they should be adding of a particular food to start their reintroduction. They can record their symptoms, their gut symptoms, and they can also record their bowel movement as well. Once you've gone through that reintroduction phase, you can actually then personalise the FODMAP diet for your patient using the filters, which are in the top right-hand corner on that food guide page. So for this particular patient, if they really have problems with fructose and sorbitols, you activate those two filters for them. You see on the left, the filters are off. on the right, they're on. And what happens when the filters are on is the overall rating will disappear, and then the app is really, it is filtered according to their own sensitivities. So anything that is green is safe for them to have. So avocado, which is very high in sorbitol, they certainly can't have it at the high doses. They can have the safe low dose of 30 grams. But you can see that the traffic lights change depending on now the filtering. So this is filtered then for that particular patient's subgroup, FODMAP subgroup sensitivities. So here's a case study of Sarah. So Sarah is a 28-year-old female. She's been suffering from bloating, wind, pain, diarrhea. Symptoms present most days, and they're usually worse at the end of the day. She's been diagnosed by her doctor, so she's done the workup for celiac disease and other deficiencies, and she has this diagnosis of IBS. She's had no symptom relief from a lactose-free diet, which is recommended to her by the medical doctor. Certainly has some increased stress over the past few months due to starting a new job. So you take your diet history, Sarah's diet history, and of course you're looking for identifying FODMAPs. So you see for breakfast here, the Raisin Bran cereal, I'd be looking at that. That'll be high in fructan. Pears will be high in sorbitol and fructose. So basically you can go through this whole meal plan and you can identify FODMAP containing foods, and you can see actually that Sarah is probably having a very high FODMAP intake from her diet. So it's going to be in dips, it'll be in chili con carnes, it'll be in gravy and pasta. So it actually is a very high fructan intake. So that gives you a very good starting point for discussing with Sarah how she can reduce that. So she starts her step 1 diet and for the 2 to 6 weeks, and she's come back after that 6 weeks and she's very happy with the symptom control, reporting about 90% improvement. Upon questioning, she reports still some gas, and she wants to know what you advise, and we tell patients this is normal, so that is fine. So I think people need to understand that it's just normal for the gut to produce gas. It does, that's what the bacteria do. So she's not to be worried about some gas. She's been able to follow the diet restriction fairly well. She's finding the removal of wheat, garlic and onion difficult when she eats out. So what is your next management plan? Well, you start the FODMAP reintroduction process to assist Sarah and identifying those triggers that will upset her. So we're going to do one FODMAP challenge, one food at a time. And we ask really what they've been missing most. It's always a good place to start. And you discuss that really with your patient. And you leave, it's around 2 to 3 days between challenges to make sure symptoms have returned to normal. And monitor the symptoms very closely by keeping a diary, and you can use the app for that. And it's really important to keep the background diet low in FODMAPs. But this is just an example of what was worked out for Sarah. You can see fructan and wheat, and excess fructose, so fructan and wheat using the onion and wholemeal bread, excess fructose using honey, galacto-oligosaccharides using some lentils, lactose, milk, sorbitol, avocado, and mannitol mushrooms, and there's some quantities there. After review of Sarah going through her challenges, her introduction period, she found the main triggers really is having onion, large quantities, mannitol, and lactose. So the long-term plan really for her is to encourage the reintroduction of foods that are well tolerated, and we do push and explain the importance of the microbiota and prebiotic effects. That's why it's important to get these foods back into the diet. We encourage ongoing testing of the onion and mannitol and lactose, even just small amounts, just to see how her tolerance may improve, and explain the occasional relapse is fine. It's not going to harm the gut. It's just, and it'll be fine after a day or two, just to go back to her diet if she has some accidental exposure. Stress is a major trigger, so it's good to talk about stress with Sarah and think about some stress management strategies. One of the common problems we have with our patients is just getting enough fibre. Often low FODMAP fruit and foods can be low in fibre, so it's really encouraging low FODMAP intake of fruits and vegetables to encourage fibre that way. And there are some low fibre sources, linseed, chia, and oat and rice bran. There can be some fibre supplements actually have been quite useful. Psyllium has been used, but that can cause some bloating for some patients. And so we tend to use the low sort of fermentable fibres, if you like. There's methicellulose, cerealia, and PHGG can be very, quite well tolerated by this patient group if you want a little bit more help with fibre supplementation. Other areas that low FODMAP diet is being used and explored with research these days is certainly children with IBS. There's a lot of research going on in that area now. Athletes who have got gastrointestinal symptoms, there's quite a bit of work being done there. One of our PhD students finished a very nice study looking at colic in breastfed infants, so changing the diet of the mother with an infant with colic actually improved the colic symptoms, which is fascinating work that's been published. It's been used to control IBS symptoms in patients with inflammatory bowel disease. That's another exciting area of dietetics, really, that's really getting a lot more attention in research these days. Women with endometriosis that have an IBS side effect, so it's been used quite successfully there as well. That area needs a bit more research. Post-infective IBS, which is basically gastro, so it is highly effective in that situation as well. Individuals who are following a gluten-free diet who do not have celiac disease. So really the latest research in this area is suggesting that it's actually not gluten in these people, rather the FODMAPs that is the problem. So certainly these people who feel that they're gluten intolerant and they do not have celiac disease, it's probably worthwhile exploring the low FODMAP diet with them. So the low FODMAP diet is a complete balanced diet. The role of the dietitian is key, though, here. So it's vital for dietitians to be trained and upskilled in this area for the best outcomes for patients. And we have at Monash developed an online training course. We've had about 600 dietitians around the world undertake this course. It is we're basically the best way of sharing all of our knowledge and expertise with dietitians. It's a very comprehensive course covering all of the areas that you need to know. It's around 10 modules long, and it's 30 CPE units, level 2. So if you're interested in this area, I highly recommend looking into this course. And other resources that Monash have developed for dietitians and patients and other health professionals to manage these conditions and use this diet. We have a very good website, monashfodmap.com. Of course, we have our app. We have our food certification program where we work with food industry. We have our online training course for dietitians, and we have a range of booklets, FODMAP booklets, resources that can be purchased as well, all to help in implementing the diet. So take-home messages from today. So really, IBS is a big problem. It's a big problem worldwide. It's a big problem in the US, around about 50 million sufferers. There's very good, strong scientific evidence for the low FODMAP diet. 3 in 4 patients will benefit from the diet, so it's very, very effective treatment. It's a 3-step program, and trained dietitians are key, we feel, to implementing the diet with their patients. There is growing interest in this area. In fact, FODMAP in 2017 was one of the top trending Google diet searches. So we know the term FODMAP is out there. People are interested in it. And I think it's important to have dietitians who are skilled and knowledgeable in this area to help its implementation where appropriate in managing gastrointestinal disorders. Oh, and that's it for me. Thank you for listening, and I'm happy to answer questions.
Jane, that was amazing. Thanks so much. We have a few questions that have come in. The first one is from Antonella, actually. How can dietitians convince GI doctors that they can refer their patients instead of giving them a one-page handout? Any advice on that?
Well, we are working very hard with the GI doctors in the US. So Professor Gibson, who is the head of our department, he's a gastroenterologist. He is talking extensively with GI doctors in the US. And I think that the message is getting across there to the doctors. The comments that we get from them in the US is they can't find trained dietitians in this area. So we are working hard to not only train the dietitians, but find a way to connect. And so we will, our trained dietitians, we will be finding ways to connect them with GI doctors in their area that they can support. So we will work to make that connection happen. And I just think the GI doctors who have gone down the road in the US of having a dietitian as part of the team have been delighted with the results. They would never go back. So I think it's just we have to get in there with key people, make these changes, show the value, and I think the rest will follow because the patients will simply go to where they're getting the best care. So it's a slow process, but we're in there and we're doing our best. We're certainly we're working very hard in that area, and we're working hard advocating the value of having a dietitian involved as part of the team with the gastroenterologist. So I think we just keep trying on all levels.
That's great. That's great. Great answer. Next question we have is around food portions. How to determine whether a meal has too high of a FODMAP load?
Well, I've used the app. The app has a lot of information about portion sizes, and the green serve or the green rating actually in the app is a very safe low serve. So and actually the way that we've designed the cutoffs for meals is that you can actually have a number of green serves per sitting, and that is safe. That should be safe. If there is a food that is actually does have some FODMAP, so actually you can see that again from the app. You can see that, okay, as I increase this particular food, I'm going to get more FODMAPs coming in, and I might be a bit more cautious with that particular food. So I think it's really just using the app, and that will get all the information is there that should help you design menu plans and meal plans for patients. So if you design a meal plan, if you're just using green serves in the app, then it should be fine.
Great. And next question was, do you recommend avoiding low FODMAP diet for elimination and reintroduction in pregnancy?
Do I recommend low FODMAP diet in pregnancy?
Avoiding, yeah. Do you recommend avoiding the low FODMAP during pregnancy?
Well, I think that, look, during pregnancy, it's very important to have a nutritionally adequate diet. Again, the dietitian is really vital there. That would be an example, probably. Look, if someone is pregnant and extremely uncomfortable, distressed with their gut symptoms, then I think you would look then at a more simplified, modified FODMAP approach, which is simply reviewing the diet of the patient who's pregnant, very carefully suggesting maybe one or two things to help. But you wouldn't probably put them on a very strict low FODMAP. You wouldn't put them on a strict low FODMAP diet for 2 to 6 weeks, and the reintroduction probably would not do that. I think you just go for a more simplified approach and just see if that can help. But I would, tread more cautiously with someone who is pregnant. It is an opportunity, though, for dietitians to review their whole diet and make sure that their diet is nutritionally adequate, though.
Gotcha. And then this next question is regarding serving sizes. So how much does serving size play a role, and how about peeled versus unpeeled fruits and vegetables?
Serving sizes, of course, has a huge role because it's a dose-dependent effect. So the more you have of a red food, the greater the symptom usually. So serving size is very important. That's why the app is such a key tool, because it gives you all the serving size information in there. You can change it from grams to ounces. That can be done in the app in the settings. So if people are not used to grams, it can certainly be changed to ounces. So that's very important to have serving size information, and that is in the app. The peeling, the analysis of foods that we've done has generally, it depends on the food. If it's an orange, obviously it's normally peeled. So we would have analysed it on the peeled orange. But something like carrots and things like that, I imagine, it's probably a good question, and we haven't done a lot of deep work yet on whether FODMAPs reside in the skin of some foods or whether they're in the flesh. For example, but for some foods we have got peeled and unpeeled version. I'm thinking of pears in there and apple. So there might be some information about whether skin's on or skin off, and it would be in the app. But I think it's an area that we probably could do a little bit more research in, for sure.
Gotcha. And is there, following on from that, is there some number of green servings that one should not go over?
Look, what you're trying to do is encourage people to eat more fruits and vegetables, and you should be able to, I mean, it's eating sensibly for a meal. So the FODMAP rating, it's on a per sitting basis. So per sitting, per meal, you should be able to have a number of green serves, and it really does depend on your appetite, but people shouldn't be overeating either. You should be able to satisfy your appetite, your nutritional needs on a per sitting basis, and have a number of green serves. And then you should be able to tolerate that. So there's no magic number to say, you know, how many green serves. It's just what you would normally have in a meal, in a sitting. It should be fine. It's fine. All of our research has been done on using, you know, complete meals. So we would make main meals would always be, could be paella or complex dishes. They've got a number of components in them, but they're all at the green serve level. And we've never had a problem, no problems with our patients tolerating that.
Gotcha. And then another question was, has there been any research done on how to prevent issues with FODMAPs in terms of the microbiome? Any kind of research around that area?
There has been a study done by the group at King's College in London. And one of the dietitians who did a PhD, Heidi Staldacker, did this work, and she did use a probiotic called VSL number 3 to see whether that could reduce. She detected changes in the bifidobacteria with the low FODMAP diet in her initial research. And so this probiotic did contain bifidobacteria, and she just wanted to see if she could, I guess, remove this, negate this sort of decrease in the bifido by having an oral probiotic. And she did manage to show that she could. So by having the probiotic, didn't get that dip in the bifidobacteria with the low FODMAP diet. But interestingly, she did find in her study that really when it came to symptom improvement, it was the low FODMAP diet on its own was still better, much more effective at resolving symptoms than the probiotic. So it's an area that needs more research, and I think we are planning to do some more research in that area, but about the use of probiotics and how and when it would be appropriate to use them. But I think it's a good question, and we need to understand that a bit better. But we're hoping that staging people through this program and not keeping them on a strict diet for very long will help to avoid some of these changes in the gut microbiota. And but again, we need to do more research in that area.
Great. I think that was the last question. Thanks again, Jane. It was a great presentation. Personally, I've actually been on the low FODMAP diet, so I want to thank you personally for all the great research that you guys do. And thank everyone for joining today. We'll send out a link for those who couldn't join today to a recorded meeting. To kind of take a little bit of a moment to talk about Tukey and what it is and our relationship with Monash. So Tukey is a form for dietitians that will be launching in a couple of weeks, and basically allows dietitians to create personalized meal plans and run tests with their patient, helping to kind of lower the gap between dietitians and their patients. It's 100% complementary with the Monash app. We recommend everyone uses it together with that. And we've been working really closely with Monash for the last year and a half. And we're excited to kind of share it with everyone. And yeah, thanks again, Jane. I really appreciate it. It's so nice to hear an Australian accent.
You're welcome. My pleasure.
And yeah, I believe there may even be a potential special code coming out after the call. So look out for an email from Tukey, and he will send you a link and a few other things shortly.
Okay, great.
Thanks so much.
Thank you. Thanks, Dave. Thanks, everyone, for listening.
See you, everyone.